All right. Okay, so my name is Jane Morton. I'm one of the project managers at VADA, and the lady who was just speaking to you is the lovely Naomi Carter. She is also a program manager from VADA. And today we also have Gary Croton, who we affectionately call Mr. Dual Diagnosis. And he is with us from the Albury-Wodonga Health Services. Gary has been working in dual diagnosis for at least 20 years, and he's also been a member of the Victorian Dual Diagnosis Initiative since its inception in about 2002. Okay, so to begin, I would just like to do an acknowledgement of country. So I would like to acknowledge the traditional owners of all the lands that we're meeting on, and pass on my respects to any elders past, present and emerging, and also give my respects to any Indigenous people who may be part of this webinar. So today, this is the third in our series of 4 webinars, and what we are going to talk about today is AOD and mental health, and particularly mental health while we've been in the situation of the COVID-19 crisis. And the COVID-19 crisis will have, I suppose, caused or predisposed to perhaps some changes in the way your clients are presenting to you, and that may well be presenting with some additional challenges, which is making it more difficult in your clinical practice to work with them. So what we're going to do to start with, Naomi is just going to have a little bit of a chat about some housekeeping in terms of polling. Then we're going to have a brief sort of 5-minute discussion, and then Gary will take over and give you lots of information on a slideshow. So Naomi.
Cool, thanks. So as we've done previously, we like to do a pre-session and a post-session poll. So the first one, which I'm just going to launch now, is if you could just please indicate here your level of confidence in managing presentations of co-occurring mental health and AOD, and particularly in this current kind of context. Cool, okay, I'm going to show that to you all, share it so you can see that most of you feel pretty okay, but you want to know more, and hence why we have Gary here. Now, the next couple of polls so thank you for that, everyone. No, stop share. The next couple of polls that we have, or the next couple of questions that we have, around whether or not you have encountered people presenting with co-occurring mental health concerns, but also, if you have, what are some of the main concerns? So you should have that poll now. Is everyone waiting for a poll, or have you got the poll? You've got it? Okay. Okay, I'm just going to share this all with you again so you can see. Quite clearly, everyone has come across this, and mainly looking at anxiety, bit of mood. Great, thank you everyone. What I will do now is hand you over to Gary. Thank you for that, because that just gives a bit of context. Hand you over to Gary to take this away.
Beautiful. Thank you, Naomi. Thank you, Jane. Okay, so we want to have a discussion for 10 minutes and just try and get more, we're all learning as we go and feeling our way in this new environment. What's happening out there? What are the main challenges? And I know that a huge percentage of your work has swapped over to working via telehealth. and we're all feeling our way with that. What are you encountering there? You know, what's the main challenges in responding to co-occurring mental health concerns in the telehealth environment? And I note in that poll it was mainly anxiety, then depression, and some psychosis. So do we just have the mics open, Naomi? Is that how it works?
I'm going to pop people into small groups.
Okay. Yep. In
Into a larger
diet.
group.
Cool.
Yep.
And then we'll come back and discuss as a large. Yeah. Beautiful.
Yep.
Beautiful.
So you're going to have 5 minutes to discuss in pairs what you're seeing as some of the main challenges, and then we'll come back and share that as a group. All right. You should be sent to a room right about now.
I'm muted.
You're unmuted now.
I'm unmuted now. Beautiful. Hi, welcome back, folks. That was a really quick 5 minutes. In our group, we didn't get much past looking at, you know, the changes in demand in the different parts. And it was really interesting. Demand was going up in the metro area, and in the rural area, if I'm paraphrasing right, Monica, it had gone down. Yeah. So what do people find? You know, did people identify some challenges in responding in the online environment? What was there? How do we unmute people when they want to talk?
I believe people can unmute themselves. I think perhaps they just don't want to.
That's all right. I mean, look, I'm happy to jump in and give a bit of feedback from, you know, the group that I was in. And Jeff was describing that a lot of clients who have the coexisting problems are now reporting heightened sense of anxiety. So even if they've got other types of disorders like schizophrenia, they're getting more anxious than they ever were. He also noted that I think 4 ex-clients have re-engaged with the service, all with anxiety, just over the past week. So yeah, anxiety is a big thing.
Yeah. And that was reflected in that initial poll. You pretty much had to just pick one concern. We probably should have had a button there for multiple concerns. Anything in there, Jane, about the challenges in trying to respond, you know, in an online environment? What are people noticing there?
We didn't quite get to that. I think the only other thing we discussed was, I mean, like with wait lists and the fact that services are offering different things, and like some of the resi rehabs actually had to discharge people to maintain social distancing, and I think several of them closed. So, you know, they're really difficult for workers to respond to that when all of a sudden someone was neatly in a rehab and then now they're not.
Yeah. And there's been lots of changes in that arm of the system. My understanding is that a lot of them are getting their protocols together and can see the day coming in the next few weeks where it's back to business and numbers as usual in the resi rehabs. I don't know whether that's universal, but it's certainly in a couple of them. Any other...
Sorry, Gary. Daniel, did you have something you wanted to add earlier at all, or was that?
Oh no, I was just unmuting, but I can.
Okay.
I just felt.
Okay, no, I don't want to put you on the spot. I just noticed you'd unmuted and then muted again, so I wondered whether you had something to say.
Not particularly. Someone does. Someone else has something better.
Cool, no worries.
I just say, I guess from my perspective, and I support young people as an AOD clinician, a lot of their coping strategies are like they can't access at the moment, and as well, like young people can't see their friends through really big protective factors. And I know that a big majority of my client group, they can't learn at home, like they just don't have the capacity to sit down, focus and do the work, and let alone motivate themselves. So like going to school, engaging with teachers and peers, it kind of you know, it's really important for them. So with that transition to like online learning, it's just not achievable for them. And then they can't like, you know, play sport or see their friends, or, you know, even like go skating. Like you're not allowed to go skateboarding at the skate park. Like, so I feel like those kinds of things are really exacerbated by their mental health. And then, you know, when I'm in sessions with them, I'm not too sure what to offer them, because like they don't have access to those things.
How willing have they been to engage, Sarah?
Sorry?
How willing to engage in the online environment with you have they been?
Majority of them are pretty good, and I guess I give them the option of text, phone, or like video call. Majority of them want phone though, so I can't really as well. That's another thing. You can't actually see how they're looking. Are they looking after themselves? Like, you know, have they deteriorated in their physical appearance or anything? But they're pretty good, but I kind of have like long-term clients. So I've been lucky in that sense.
Yeah, so you know them fairly well, so it's easier to sort of spot the changes.
Yeah.
And in that first bit of feedback you gave, it sounds like people who, in some respects, are, you know, to some degree, are off the bus already. You know, they don't have all the resources that a lot of their peers would have. You know, unequally impacted by this. Is that a sort of fair summary of what you're saying at the start?
Yeah, that they don't have the resources or tools that we've kind of talked about, we've established. And I feel like they're kind of lost as well, because they don't really have their sense of identity, because it's just like, well, I can't connect with all these things that are really important to me. So consequently, substance use increases because of boredom, which then in turn can exacerbate mental health. So it becomes this.
Yep. Spiraling sort of cycle. Yep.
Yeah.
Are you in metro or rural? Can I ask Sarah?
I cover Bayside and the Northwest.
Wow. Okay. Yeah. So a bit of both. Others, what are other people noticing, particularly in working in the online environment? Don't be shy.
Okay. We were talking in our group how initially it was very quiet when it first happened. Not a lot of contact, but I've noticed for me personally, and the rest of our team, so we rural, and we're getting way more engagement. And I think that has to do with the ease of being on the phone rather than having to come in, and not much happening.
Yep.
So some people talk about intake worker for ages, which is kind of funny.
So you're getting feedback that people are liking it, Daniel?
We are actually. Some people find it uncomfortable, but I think Sarah said, most people prefer the phone rather than the video call.
Yeah.
But yeah, people are finding it easier.
Yeah, beautiful. All right. Any last bids on what people are noticing? Anybody got something burning to say before we move into a bit of death by PowerPoint?
I just wanted to comment that in terms of the caseload for the counsellors, they're finding that it's very difficult to exit people from the counselling because even if their substance use may be, you know, to the point where they would normally consider exiting the client, because of their anxiety, because of their increased anxiety issues around the current COVID situation, they're finding it a lot harder to exit them out of counselling. So we're sort of now having to start to think about, well, this is a bit of an issue because we've got people in the outer east of Melbourne who need to come through, who are waiting to come through, and our caseloads are becoming quite blocked. So we're going to have to start looking at some referral pathways for people in terms of, so that we can exit them and refer them onto a more perhaps appropriate service to be working with the anxiety.
Yeah. So the anxiety associated with COVID and isolation and all those.
Yes. Yeah. So whereas under normal circumstances, they would have reached to points with their substance use that you might be able to say, okay, well, you're going really well, we'll exit you now, you can always come back if you but because they've got this additional complexity now around this extra anxiety in this environment and the isolation in that they enjoy receiving the phone calls from someone, it's really hard for the clinicians to let go, and for the client to exit too. So we've just noticed a little bit of complexity there that we're going to have to work through.
Yeah, so discharge, yeah, and moving through the
Yeah.
system. In mental health, Elaine, we've noticed that working online, sessions tend to be briefer but more frequent. So clinicians are working much harder. They're working hard enough already, but they're working even harder now and bouncing from one online session to the next, but with shorter sessions. Is there anything parallel like that happening in drug and alcohol?
Initially, that was the case. But as clients have got more and more used to this online work, some of them are actually, it seems that some are actually preferring it and are engaging quite well in some therapeutic work. So at the beginning, it was, a few weeks ago, it was as you were describing it, but it's changing.
Yeah, yeah. So as we get familiar with the environment, it's becoming easier to go deeper and to do more, psychodynamic therapeutic work.
Yes.
Yeah. Awesome. All right. Naomi's going to be on the case to keep it moving along. This is a short chat session. I'll share my screen and we'll work through the PowerPoint. Hopefully. Share. Beautiful. Slideshow from current slide. And we're just going to do less than 20 minutes of PowerPoint. We'll move fast, hang on to your hats, and use that as a prompt for some more discussion on the other side. Okay, so managing increased presentations of people with dual diagnosis and experiences of mental distress, responding to people with co-occurring mental health and substance use. You guys will get this PowerPoint, or if you want to, you can download this PowerPoint as a PDF when it goes up online on the VADA site. And we tried to design it as a resource that if you click on any of the images in the PowerPoint, such as that image of the VDDI logo there, you will jump to more information about the image that's portrayed. The VDDI stuff there has the contact details of your local dual diagnosis worker, if that's useful to you, and a profile of the work that the VDDI does. Okay, so background context. Dual diagnosis in drug and alcohol and mental health services. I usually start most presentations around this, why, I'm a drug and alcohol worker, why do co-occurring mental health concerns matter to me? And it's the dual diagnosis trifecta, prevalence, harms, and the exciting bit is the potential for better outcomes. We know that, those broad population surveys, dual diagnosis is really common in the general population. In treated populations, in drug and alcohol services, in mental health services, it is the expectation, not the exception, for very good reasons. If you've got a drug and alcohol concern, you're much more at risk of having a mental health concern for very good reasons, and vice versa. Some of the numbers, Murray Thiessen, she's done the best trawling of the Australian data, and she puts the numbers in mental health services at about 71% of the people who come through the door have got a substance use issue, and in drug and alcohol services about 90%. Be curious to hear at the end of this how that aligns with your experience. Some sub areas that we work in, maybe that's not so true. People with methamphetamine concerns, 11 times greater prevalence of psychotic symptoms amongst people who use meth. Great study. The Matilda Centre in New South Wales, they put the numbers at about 75% in drug and alcohol settings. 3 in 4 of clients have got a comorbid mental health concern. And Odyssey in Sydney has been doing some great data in their annual reports, for the last nearly 10 years. And the really interesting thing there is that the numbers keep going up to where, this is their latest data, this came out about 8 weeks ago, and they said that 77% of the clients that they see in AOD Resi Rehab have got co-occurring mental health concerns. And they remarked in their press release around it that these numbers just keep going up and up and up. And there's a component of that which is due to increased recognition, but it does also appear to be some sort of an argument that the complexity of people's presentation is increasing. And we know, I won't dwell on this, there's lots of harms. A person who's just got a mental health concern alone compared to somebody who's got both, or a person who's just got a drug and alcohol concern alone compared to somebody who's got both, generally we'll have many less impacts. We'll have a much less complex presentation. You know, we know that people seldom have just mental health and substance use together. Most often there's a host of other concerns and needs for treatment that accompany it for very good reasons. Housing instability, loss to carers and significant others, unemployment, people with dual diagnosis and other complex needs. So that's prevalence, harms. A really exciting thing is that, you know, because mental health and substance use concerns influence each other in how in their onset, in their severity, in how well they respond to treatment, and in their relapse circumstances. You know, I do a lot of assessments of people with complex mental health and substance use, and I will always try and establish what's causing what comes first chronologically, what happens when a person uses less. Most often I cannot tease out what's causing what. You know, the mental health impacts on the substance use impacts on the mental health. The two are really intimately intertwined. And the exciting bit about that, you know, we work in drug and alcohol. If we can, anything we can do to increase our recognition and effective responses to mental health concerns, we're going to be more effective in responding to substance use concerns, and vice versa for people working in mental health. Okay, that's background, COVID and mental health. What are we seeing? This is just, you know, I'm 63. This is the most extraordinary period that I've seen in my short life. You know, the pace of change has been really rapid. There's a great deal of fear, uncertainty, lots of dramatic news headlines that it's a really shifting dynamic really quickly. Lots of members of our community have experienced lots of losses, job losses, economic losses. Loss of security is really, really significant. It came out in your discussion then, you know, loss of supports, particularly with the young people. You know, they can't do the things that they would normally do to establish and develop their identity. Loss of physical contact, isolation impacts. Lots of concerns emerging in mental health, and I wonder if it's the same in drug and alcohol about DV. You know, recognising an increased prevalence due to isolation. We're all challenged by working at home, homeschooling. My young one is in the next room at the moment. I hope he stays quiet for the duration. Increase in substance use. It was really interesting to hear those divergence of opinions there. We've got really good data now from the ADF that alcohol use has gone right up. You know, there's really solid data about that. Anyone wants to email me, I'll pass that on. Changes in drug supplies, you know, it's harder with isolation. How do you go out and score? You know, all those sorts of things. So we've got two groups of people with mental health concerns that we're really seeing. Emerging mental health concerns and disorders that are probably related to isolation, to the pandemic, the effects of the pandemic, and the exacerbation of existing mental health concerns and disorders and drug and alcohol concerns. And weaved all through that, you know, we know that when things like this happen, the people who have the biggest impact, the people who wear it the most are those people who are already off the bus. You know, those people who are already, you know, have got multiple and complex needs. The impact on them is going to be greater than on people who are socially connected, of course. You know, it's a given. You know, the populations that we often see in our services. Okay. Changes due to COVID in our drug and alcohol and mental health services. Again, an extraordinary period in our history. That's a link to a video that's just gone up today. That's from the feds. They say that half of mental health consultations in Australia are now being conducted via telehealth since COVID. I polled a lot of my colleagues around the state, and pretty much it was consistent, the feedback. We're seeing an extraordinary change in mental health services, and it sounds like in drug and alcohol too, particularly mental health services, though, from acute inpatient care to treatment in the community. You know, there's an argument that this is where mental health services should have been since deinstitutionalisation, and now, because of COVID, you know, there might be silver linings to this. We are rapidly moving to that. We're doing everything we can to prevent an admission. It's not a default setting, and we've really kicked up and developed our responses to try and prevent any unnecessary admissions. Along with that has come a really full-blooded recognition that, you know, clinical mental health services, to be effective in the community, they have to become really more like drug and alcohol services and meaningfully strength-based. You know, like not just not a nod and a wink and we'll identify a couple of strengths at the end of an assessment. We have to evoke a person's strengths. We have to grapple much more with their social circumstances, what's going well, who their supports are, all those positives, and work with that. So that's for me, that's a hugely exciting change in normal business for mental health services. There has to be a greater focus on working in partnerships. Again, that can be really good news for dual diagnosis, you know, so meaningful partnerships with other workers, meaningful partnerships with significant others, and much greater reliance on the feedback and the work of significant others, much greater recognition of the impact that they have. I mentioned already that we're tending to have more frequent briefer phone and telehealth contacts, and I'm really interested in Elaine's observation that tended to be an initial observation in drug and alcohol, but now it's becoming, you know, it's tending to go deeper as we all get familiar with the technologies. And we've had rapid development in our skills and capacity to work in telehealth. The feedback I'm getting from drug and alcohol services, you know, a similar rapid shift to telehealth health modalities. It would be great to know what percentage of contacts are happening via telehealth these days vis-a-vis face-to-face. My suspicion in local drug and alcohol services is that it would be greater than 50%. Referral numbers, or local feedback I have is that referral numbers are about the same, but I noticed what Elaine said there, that in our small group, that it was, and she works in the Outer East, that it was really quiet initially in the first few weeks of COVID, but the numbers are ramping right up now and exacerbated by difficulties with people discharging, moving through treatment. So concerns about that. I won't labour all the multiple changes in pharmacotherapy, really exciting changes, increased demand for family drug support, and again with youth like Sarah, it was reflecting some of that. Often there's a preference for in-person contacts. Yeah, okay. So, drug and alcohol responses to people with co-occurring mental health concerns. I better speed this up a bit. I guess they're really around a recognition that there's different predominant cohorts. You know, dual diagnosis is the expectation, not the exception, in drug and alcohol and in mental health, but we're talking about broadly two different populations. In mental health, they tend to be people with severe mental illness co-occurring with a range of different substance use concerns and severity of concerns. In drug and alcohol, we're talking predominantly about people with what tend to be more severe substance use issues co-occurring with high prevalence mental health disorders. And this was reflected, I guess, in the feedback at the start. Anxiety, depression, and trauma is almost a given. It was really interesting to see that there was some amount of psychoses in that initial feedback. I'll make a few references to the cross-sector 2007 Victorian dual diagnosis policy. That's got a beautiful little graph in there. The blue in the middle is the AOD service system, and it's designated in that they respond to people with, you know, more severe substance use issues co-occurring with a range of high-prevalent mental health disorders. At the top there, you've got mental health services who respond to people with more severe mental health disorders co-occurring with a range of possible substance use concerns. It's a useful thing to direct traffic. We've got some policy guidance. You know, that 2007 policy is still current, still up. If you click on this when you get the PDF, there's a clear statement in that if you work in mental health, if you work in drug and alcohol, responding to both concerns is core business. It's unarguable in there, and a notion that workers need to be developing their dual diagnosis capability to be effective in responding in an integrated manner to both concerns. In that policy, it actually spells out what being dual diagnosis capable means, you know, and it's parallel for mental health workers, but for all drug and alcohol workers, the capacity to screen for co-occurring mental health concerns, to conduct an integrated assessment, and to seek secondary consultation, and for advanced AOD workers, the capacity to provide integrated treatment, you know, tending to be a one-stop shop, responding to both the mental health and the substance use concerns together. Okay, we're galloping here. We've got a couple more minutes. I'm on track, Naomi, I hope. Telehealth responses to mental health concerns. And I know you guys have covered a lot of this in the earlier sessions, but safety is paramount. Whenever we begin a new telehealth consult, you know, it's good practice to identify where the person is, just in case, you know, something goes wrong, something changes. So what their location is, a few of their contacts, not just what their email contact is, but what their phone contact is. And hopefully if you can, what support people they've got and their contacts. You know, is there somebody, you know, if things go wrong, what can we then do about that? These are some of the parameters of dual diagnosis capability. A big focus on engagement and welcoming, back to the McDermott and Pyatt 2007, 1999, you know, Melbourne Uni, they tracked a whole lot of people with severe co-occurring mental health and substance use around Melbourne, and they found that most often, you know, they engaged with an incredible number of services. The service they most often received was referral onto another service. There's a huge recognition in dual diagnosis that people who've got multiple concerns, people with the most complex needs, rather than being a priority for treatment, are the people who are most likely to fall through the gaps and either receive no treatment or receive inadequate treatment. That's a given in dual diagnosis. Hence the real focus on welcoming. You know, we're doing everything we can to engage people, change our rules, change our approach to stop them falling through the gaps, and to make a safe place where people can have those useful conversations that lead to change. Trauma-informed principles are absolutely critical there. You know, one of the curious things that I find about trauma-informed principles, which are just fantastic, I support them so strongly, is that these are things that should be given for everybody who walks through the door. These are things that are necessary to welcome and engage anybody who comes through the door. Yeah, and I've got to say, drug and alcohol workers, from my observations, are absolutely leading the way in their ability to develop a trauma-informed service system. So we need to have a huge focus to stop people falling through the gaps on engagement. You know, specific to telehealth, you know, we need to have consent. We need to have already adjusted our universal consent forms to include a telehealth consent. Routinely, we need to assess people as close as possible to when we first engage with them about what their access to telehealth is, what their comfort with it is, what their skills are, what their preferences are, and being mindful that the people with the most complex co-occurring mental health and substance use and other complex needs are least likely to have good access. They're more likely to have impaired access and more likely to have impaired skills with the technologies. You know, have they got a private space to talk? What's their preference? You know, is it phone or online? What works for them? What's their preferred times? Is it after the kids go to school? Is there a window sometime in the day when we can have a private conversation after, you know, partner goes to work, whatever that is? And it's become now part of our core skills, part of our responsibilities to provide education re telehealth, try and link people in, try and develop their capacity to engage in telehealth, and also significant others, you know, given that we have to respond to, we need to respond to their needs as well. Okay, so moving along, screening and assessment. You guys in working Victorian Drug and Alcohol, you are so far ahead of mental health because you have got this beautiful suite of assessment forms that I know can be a pain to fill out, but there are so many great options in those, and they've developed so well. One of the screens in there in the initial assessment that I really, really like is the K10. You know, that's essentially just a measure of distress. And I think it's really, really useful in this COVID environment. You know, and 10 to 19, low psychological distress, 20 to 24 mild, 25 to 29 moderate, and 30 to 50 high. That's a great indicator of generalized stress. Yep. And there's an argument that if people get 30 to 50, they may have severe mental illness. I don't know about that, but you know, certainly, you know, it's clinician judgment. Just great screening and assessment forms in the universal suite there, with lots of room to try and identify what's going on with mental health. The risk assessment, again, really, really good, and a useful thing to work through. you know, and it's going to be clinician, you know, we all have to develop to be able to do these things online. I really like that in the final summary sheet in the universal assessment suite, it has substance use up there with equal prominence right alongside mental health. It's a stellar suite. The optional modules, which are also great, you know, you've got the modified mini in there, which is, again, if it's useful, if you're wondering, you know, what's going on here, is there more going on with the mental health? The modified mini, and if you look at the sub-scores of it, it's you know, still a screen, but it can give you a lot of diagnostic information. You know, is there a psychosis going on here? Maybe try a modified mini. That will be a good way to tease it out. And again, with SideCheck, a really, really useful tool. Okay. The Australian guidelines for drug and alcohol services on co-occurring alcohol and other drug and mental health. These are stellar guidelines. We're up to the 2nd edition now. They also include a range of screeners they describe them, and most of them are available in the appendices. You know, there's a psychosis screener there, a trauma screen, eating disorders, really, really useful tools. So that's screening, assessment, detection of co-occurring mental health and substance use, integrated support and treatment. You know, remembering that we work in Victorian drug and alcohol, it's part of core business. We all have to have the capacity to respond to both concerns. The Victorian policy has got a really useful, operationally achievable definition of integrated treatment, which is that one worker or clinician or team treats both concerns. And generally, that will be often the only possible response, and often it's the best response. Won't fit all situations. You know, drug and alcohol services aren't set up to deal with acute, immediate suicidality. That does require a referral across to clinical mental health, in the same way that clinical mental health aren't set up to respond generally to acute complex withdrawal. That will require a referral across to drug and alcohol. But where it can be achieved, best practice is to treat both concerns integrated in the one spot. Where that's not possible, we work with our partners in the other specialist service, hopefully around a single ISP or an agreement that says, we'll keep talking. And this is the area that you'll focus on. This is the area that I'll focus on. How are we going for time? In terms of the specifics, we've gone over time. I'm going to have to go faster. Again, those national guidelines have great resources and guidance about responding to anxiety, depression, ADHD, psychosis, bipolar disorders. They should be our first stop when we're wondering how to respond to co-occurring mental health concerns. In this telehealth environment, we really need to consider, would it be useful? You know, is this a person who's really skilled at, oriented to, maybe in a rural area, to doing online, you know, working through online e-health options? We will put in a link to this. This is the latest version of the mental health practice link to all the, you know, these are the best quality e-apps for responding to mental health concerns. You can't do better than this list. Everything on here is solid gold, and there'll be a link to it in the PowerPoint. No wrong door. Again, that idea that every door in the healthcare system is the right door. I might come to mental health and they look at me and say, no, 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 you belong over in drug and alcohol. They don't just say, here's a card and off you go. They bring me into their system, they meaningfully welcome me, and they maybe do everything they can to hook me in, you know, work with me until I'm hooked in with drug and alcohol services, and vice versa. Okay, and we still want to build a no wrong door service system. The guts of that, the real guts of it, is that we need to know somebody on the end of the phone in the opposite service. You know, that should be a challenge. If we work in drug and alcohol, we should actually know a few of the mental health workers that we can ring up to for consultation, for advice, to work with. We tend to only meet around when there's complex people, around divisions around complex people. When it's quiet, that's the time to try and build our relationship with people in the other sector. And that's, you know, if we meet around complex people, then there's room for misunderstandings and room for disagreements. You know, there's that guide that you need 7 good exchanges with everybody for every difficult one. Doing everything we can, invite them to our education, send workers over there for placements when it's possible, bus trips, randomised coffee trials. There's a lot that can be done when it's quiet to build those relationships. Okay, So, 5 minutes over time, sorry, Naomi. There's lots of resources. Again, when you get this as a PDF, click on any of the links and you will hyperlink to them. And I love this. I just ran across this yesterday. I'm putting this together, the Pandemic Kindness Movement for Clinicians. It looks just great. I really urge everybody to click in there. Okay, and there's my contacts. I'm very happy to talk to anybody anytime about dual diagnosis. If you want to get on any of my mailing lists, please do, but beware of spam. I won't be offended if you say no more. All right, stop the screen share, and it's 2:48. All right, can we just have a bit of a discussion about that, the content of that PowerPoint and anything that was said earlier on. We've got 7 minutes, so we might not go into small groups. I'd really like to hear any comments, violent disagreements, anything that was useful in there, anything that people might think they might try in response to anything that we've discussed so far in today's session. Over to you guys. Don't be shy.
They're very shy. At least it gives you a chance to catch your breath.
Yeah.
Oh, sorry, me again. I guess for me, what I picked out of that, there were a few things, but is I must write an email to the clinicians around reminding them about with the telehouse, just check the change in delivery, that we just have to make sure that people do, we're offering people a time when they can have that privacy. That's really important. And checking on people's locations and contacts, just in case during the consultation it doesn't go well and there's a need maybe to contact an emergency service or an emergency contact. So for me, I thought, yes, I must remember to send that email out to the team. I think we might have discussed something about it at the very early stages, but maybe not later on. And then looking at some of the resources, going back, looking at your PowerPoint, and just really unpacking some of those resources to make sure that if we can possibly, introduce someone to an appropriate referral pathway to keep our caseloads moving, that we can, whilst at the same time, yes, acknowledging that we are dual diagnosis competent, but yeah, it's that fine balance.
Yeah. And discrimination and knowing, when we do refer or, and take referrals, all that sort of stuff. What's been your experience of working with clinical mental health? Good, bad, indifferent? Do people routinely ring clinical mental health for consultation around complex mental health concerns or receive calls about complex AOD concerns? What's people's experience there?
Can I say something? I think my experience has been similar to what you said, is that you generally tend to meet people around complex clients, but then once that connection's made and their name pop up, you can feel easy to give them a bell. And I find it useful to get on the same page, just even with simple things around what they're into and who's supportive at the moment and those kind of things.
Yep.
So that's my reflection. But yeah, haven't done it proactively.
Yep. In the quiet times, Daniel, one of the things we tried up here was those randomised coffee trials 2 years ago, and it was the first time I'd heard of them in Australia. But essentially, what we did was we got call for expressions of interest from the drug and alcohol workers, from the mental health workers, and then we did sort of blind dates. Here's such and such, and we gave each of them $10 and said, go and get a cup of coffee and talk about whatever you like. And the feedback mechanism was, we want to know one thing you've learned about working in the other sector that you didn't know before that. And it was fascinating. There was some really unexpected outcomes. I think there was one case where these workers realised that, over in the community health service that auspiced the drug and alcohol service, there was a parallel program that was doing much the same with young people as was happening in the mental health service, and neither knew about the other. So they were doing this very, very similar work. Probably less than 500 metres from each other, and neither knew about the other program. It's easy to have gaps in the system, and those conversations they're really useful if you can keep them running. Yep. So routinely inviting people to any training we're doing. Trauma informed is a great training there to that we're all all our services need to become more trauma informed. Why don't we auspice joint training? Anything we can do to build the understanding of what it's like to work out the system, what the strengths and the challenges are. Most mental health workers, when they think about drug and alcohol, they think that you guys are the same as them. They don't realise that the very different focus that that you guys are much more genuinely strengths focused, and that you don't have the legislative background that you have in mental health. So there's frustrations for mental health workers when they misinterpret what drug and alcohol workers do. So any context that can be built, it's always productive. Yeah. Any other thoughts and comments, concerns? Any violent disagreement about it being core business?
I had a question for everyone else. Has anyone had any good experiences with apps offering to clients?
Apps, did you say?
Mm-hmm.
Good.
No.
I can't comment on that one. No.
You can type it in the chat if you don't feel like actually speaking.
Just in regards to apps, my clients have been using drug and alcohol apps, and the ones that they've recommended is I Am Sober, which is around any sort of substances working towards abstinence. And then the other one that they've used is called Grounded, and that's purely about cannabis use and reduction and tracking how they're going with that. So they're the apps that my young people use predominantly, but not in regards to mental health.
Yeah, there's
also loads of there's loads of mindfulness-based apps as well, like Smiling Minds and that sort of thing, which are free and sort of can be clients can access tolerable amounts of time to do it, whether it's 2 minutes, 10 minutes, and whether they're guided or just got background noise and that sort of stuff. So there's actually quite a lot of apps around mindfulness.
Yeah, that's what I mean. There's way too many. It's hard to know which ones are good.
Yeah, this list here, you can back it in, which we will circulate the link to. That's, they are all evidence-based. They would be the ones, all the ones on that list that I would really, really recommend. The wisdom seems to be that apps are best used as an adjunct to treatment. You still, the sine qua non is you still have a one-to-one relationship at the heart, but some of those apps are really useful to for homework. But probably there's nothing that beats a one-to-one relationship. The other area where apps have got a lot of recognition is when there's issues of stigma, and there's nothing more stigmatized than having both a mental health and a substance use concern. So, for some, particularly in rural areas where stigma and discrimination is worse, where people don't want to be identified, sometimes, an app is the only possible thing, and they can be really good, particularly if the person's competent and oriented to work through electronic means. All right.
Are there any final questions or comments or things that people feel that they want to take away that they'll be able to apply?
Could I ask a question, if I could, please? We had a situation last week where a client was discharged from the psychiatric ward, and they became unwell. So we contacted the mental health triage team, who visited this client, but said that they had been transferred across to one of the community mental health clinics, Murnong or Chandler. And on speaking to the mental health clinic, they said, yes, they have been referred to us, but we've got a waiting list of 3 or 4 weeks. So we asked what would happen, what should we be doing with this client in the meantime if they become unwell? The duty worker responded that you would have to ring mental health triage. Mental health triage told us that no, you have to ring the duty worker. There seems to be a bit of a gap here, and I just wondered if anybody knew what the answer was. Because this is something that we have to follow up. And I wondered if you might know the answer.
I don't know the answer. I work in a rural environment, and one of the benefits of working in a rural environment is that it tends to be much more seamless. You would not encounter that pass the parcel type stuff in a rural environment. And I know you work in a huge area where those teams can be geographically separate. They may not know each other in each team. It's a concern, there's parallel things have happened in recent years in drug and alcohol. I'm no fan myself of production line models of treatment. I think it's great if the person who welcomes the person into the service can be the person who tends to accompany them right through the journey as much as possible. We need client-centered approaches, not production line models. And you've just done a beautiful example, Elaine, of where they can so easily break down.
Okay, looks like we'll have to follow that one up a bit more. You don't know, do you, Tennille, by any chance?
No, where there's been a gap, we've just kept talking with triage, and if they need reassessing, they do the reassessment whenever the client reaches that acute stage again. So I haven't been passed around like that before. I just, sorry.
I think it's just that the waiting lists are perhaps a little longer in community mental health because it's shifting towards community mental health, and perhaps they're becoming a little overwhelmed. So we'll just have to keep our eye on it.
I'll have to develop a system.
It shouldn't happen.
And with the final minute, because I know Gary has to go bang on 3, so he might disappear from our screens, but if everyone else wouldn't mind just completing the final poll, the post-session poll, that would be, I'd be very grateful. I'm going to pop it up now. There's 2 questions, very similar to what you answered if you've been in the session before.
And before you go, Gary, I would just like to say thank you on behalf of Naomi and I for joining our session today. It's really, really informative. And,
Thanks, guys, for inviting me. Lovely to meet you all and have a quick talk. It was too short, but I got to go. Okay,
thanks, Gary.
See you, Gary. Thank you.
Bye.
Bye.
Okay, I'm going to share this. Amazing. So again, it appears that, PowerPoint's super helpful. People still feeling confident but wanting to know more. What would be really, really helpful for us is to have a little bit more information about what you want to know more about. So even if you email me or email Jane, just to give some detail, what is it specifically that you'd like to know more about? Is it the actual techniques? Is it the practice that you engage in? Is it the referral pathways? Anything that you can give us that gives us a little bit more idea about the specifics of what you'd like. We'll do our absolute best to find that for you, and perhaps look at running some other sessions to give you that information. Because it feels, I mean, particularly from the words that Gary was speaking, that the AOD sector are pretty strong in being able to manage co-occurring presentations. So whatever we can do to support that, please let us know.
Will do.
Amazing, because that's the point. The point is to support you. So if we're not 100% on what you need, we can't do that really well. So definitely let us know. Don't be shy. Don't be shy. And next week we have a couple of the specialist family violence advisors who will be presenting in a similar way that Gary did today, to provide some more information around how to identify, how to respond to, and also how to refer if you are noticing that some of your clients are experiencing family violence or perpetrating family violence. So that will be our last session. And then further to that, if we can provide you any more information, we will. So thank you all for your attendance today. Thanks for coming along. I hope it was helpful, and we'll hopefully see you all again next week. Cool.
Thanks, Naomi.
Ciao.